Good morning, everybody. So many familiar faces. I hope I have time to catch up with most all of you in the course of the day. So thank you so much, first of all, for the invitation to be here. So I'm so grateful to Patricia and to Audrey for this opportunity. And I'm going to be talking to you about self-care. I'm going to be introducing the idea in the title that actually finding a way of being with our pain is an important, in fact, a central element to sustaining ourselves in the work we do, those of us that are doing this work every day. And the format of my presentation, you can see from the program that I'm with you for the next hour and 30 to 40 minutes. And during that time, I'm going to talk for the first part, in the middle of which I'll pause a little bit and take any questions or comments from the floor. And then we'll have some more opportunity for that at the end of the talk. And then I'm going to lead you in a short little guided meditation, which will arise from the material in the talk. It'll become clearer what that's about as we go along. And then finally, I'm going to lead you into a short reflective exercise where you just reflect on some questions for yourself and maybe have some discussion with your partners. So let's begin. Let's see, sorry. Yeah, that's the one I'm doing. Yeah, sure. So, I'm going to tell you a story, and the story begins with working on this paper, which I was one of the authors on and which was published in 2009 on self-care. And I learned a lot in the course of working on this paper, and I'm going to review some of that to start out with. And some of this material will be very familiar to many of you. But I learned that there really are three common caregiver stress syndromes that we recognize. Perhaps the one we all identify most easily is burnout. That's certainly a term that's familiar to all of us. Perhaps not quite so familiar is the concept of vicarious traumatization or moral distress syndrome. So let me just say a little bit about each of these to begin with. So one of the characteristics of burnout is that it's a syndrome that results from the stresses, the sort of stresses that arise between us and our work environment. The sort of environmental or in some ways bureaucratic type stresses. Maslach, who did a lot of the early work on burnout, at the time of her initial studies, found a prevalence of 30% of doctors and nurses were suffering from burnout. I suspect it's higher than that in certain circumstances. And indeed, some studies have shown that within some specialties, it's actually a lot higher. For example, in pediatric oncology, there's a figure of sort of 50% or so. Also interesting, perhaps, is that the prevalence of burnout in palliative care clinicians is less than in oncologists. So that's something just interesting to note. Perhaps one of the reasons for that is that medical oncologists, as Dr. C, who is one of the characters we followed in the course of that JAMA paper, are kind of dealing with more of those kind of bureaucratic stresses on a day-to-day basis. As he says here, the stuff that burns me out has nothing to do with loss, with losing my patients, with what they're going through. It's fighting with insurance companies. So that's the kind of stress, that kind of stress over time gives rise to burnout. And then some specific stressors to our work in palliative care, hospice care, end-of-life care. Finding ourselves in a situation where we just don't have the kind of time we want, we need with our dying or seriously ill patients and their families. Not having the time or not taking the time to actually acknowledge and work with our own emotions and grieving. Because there's the need to carry on as usual to the next patient and the next patient and the next patient. And this final one is one that certainly I realize made a lot of sense to me, and that is realizing that I was really holding an internalized sense of how I wanted it to be for each of my patients and their families, and just not being able to provide that, at least not every time, or perhaps even not most of the time. Kind of having an idealized version maybe of what a good death might be, and kind of falling short of that. So Maslow kind of proposes this model, which I think is interesting as well, and that is that in terms of occupational stressors that lead to burnout, we could think of these 6 different areas: workload control, reward, community, fairness, and values. And as she puts it, the greater the mismatch between an individual and their work environment in any of these areas, the greater the likelihood of burnout. The better match or fit is associated with greater engagement and work. In other words, the opposite is also true, that the better the fit between you as an individual and your work environment in terms of those 6 areas, the more likely you are to be satisfied in your work. So that's something specific to the genesis of burnout, or the etiology of burnout. But there's another, the other kind of characteristics of burnout that distinguish it are the actual symptoms of burnout. So the symptoms of burnout are of overwhelming exhaustion. I think that's in a way the sort of bottom line, a type of physical and emotional exhaustion that it's hard to get over. You don't get over it with a good night's sleep. You don't get over it with a good weekend off. Even a holiday doesn't quite do it. It's really like you're running on empty. The second is a certain dissociation from the work itself. You're just not as engaged as you were before. You're there, but you're a little bit there on autopilot. And the third is a sense of ineffectiveness or lack of personal accomplishment. A feeling a bit like a moment ago I was describing, that sense of having some kind of internalized goal that you're constantly not achieving. The quality of your work isn't the way you'd like it to be, not just on one occasion, but over and over. And then we're kind of all familiar, and I haven't got numbers here or statistics, but burnt out is not just good for the individual. It's also not good for the individual's family. It's not good for the individual's patients. It's not good for the individual's colleagues. A higher risk of substance abuse, anxiety, depression, more medical errors, sort of that detachment and dissociation leading to a sort of loss of empathy, and a kind of leaving clinical practice, not staying in the work. So that's a little bit about burnout. Vicarious traumatization is something quite distinct from burnout, distinct in 2 ways. One, in its genesis, in its etiology. And that is because vicarious traumatization, as the term implies, is where you as a caregiver, as a clinician, become secondarily traumatized by being close to somebody who is suffering. So you're close to somebody who's going through a lot of suffering. You're present, you're empathic, you're open, which of course we all want to be in terms of helping our patients. But as Charles Figley, who writes a lot about compassion fatigue, says, that makes us more vulnerable to becoming secondarily traumatized. And that over time gives rise to this syndrome of vicarious traumatization, also known as compassion fatigue or secondary traumatic stress disorder. And the symptoms of vicarious traumatization, in contrast to the symptoms of burnout, are the symptoms of post-traumatic stress disorder. Increased arousal, re-experiencing the traumatic experience, and avoiding re-traumatization. So the increased arousal may be hypervigilance, irritability. It doesn't take much to kind of set you off, difficulty in concentrating. The re-experiencing may be kind of just having flashbacks, kind of the thought of whatever it was that happened kind of coming back, maybe interfering your sleep. And then something happens which is a reminder of your work, and that causing distress as it kind of triggers the memory of the trauma. And then finding that you begin to avoid similar situations in the future if you can. Over time, maybe even leading to a certain numbness and dissociation. Moral distress syndrome, again, distinct from burnout, distinct from vicarious traumatization, and an occupational stress syndrome that's really been articulated in the nursing literature in the last maybe 20 years or so. But I think as I've kind of learned a little more about moral distress syndrome, I think it's something that perhaps is very prevalent. And this is what happens. Moral distress occurs when an individual knows the right thing to do internally, by their internal sort of moral sense or ethical sense, their internal moral compass. They know the right thing to do, but they're prevented from acting on that by their environment, by external constraints. And that can happen once, but it can happen over and over again. So it may, for example, be looking after somebody in an intensive care unit who is clearly has had multi-organ failure, who is being kept alive at this stage, is still on a ventilator, and is coming to a point where decisions have to be made about whether or not to do a tracheostomy, whether or not to put in a feeding tube, and at this stage the liver has shut down, the kidneys have shut down, and the nurse looking after that patient, every time she or he has to do something in terms of giving care, is seeing how that's registering as causing distress and discomfort to the patient, and has to carry on doing that, and has this kind of a strong sense that perhaps in a situation like this, one should just kind of let nature take its course, that's what's happening in the body anyway, but the family want to continue, want to press on. And so there may be that kind of conflict between the nurse's internal sense of what they feel the right thing to do is, and what they're constrained in acting on and need to do because of their external environment. And that can give rise to feelings of frustration, of impotence, and feeling isolated, of being devalued, marginalized. Again, it can lead to clinicians leaving their work if this happens over time repeatedly, and can lead to a kind of a lingering sense of being compromised, of not being valued, not being seen, which has been termed moral residue. And over time, that can erode one's sense of self-worth. Now, a common endpoint of, obviously, burnout leads to those symptoms of exhaustion, dissociation, and lack of personal accomplishment. But vicarious traumatization and moral distress syndrome, while having their own specific symptomatology, if they become chronic, they lead to burnout. So burnout is the common endpoint of all those three different syndromes. So that's just a little bit of kind of general background on those three occupational stress syndromes. And, in terms of the story I'm telling, I was learning this. A lot of this was new to me as I was kind of researching for the article. And I was looking at these three symptoms of, burnout, I had a sort of an aha moment, and I recognized, that's me. I really was experiencing a little bit of all three of those, plus a fourth one, which I did add in, which was, what else could I be doing with my life? I've been doing this long enough, and seriously thinking about career change, which was, as some of you possibly have discovered, not a very easy thing to do when you're sort of well established in your career. And so so that was a little bit of a wake-up call for me, but also it was valuable. And part of the value was realizing that there actually are things you can do about it. There really are ways of practicing self-care, and we're going to hear more of those from the other speakers in the course of today. But the way I thought about it and the way we articulated it in our article was in terms of two different models which we presented in the article. The first is what we might call a practical model. So I'm really presenting here today three different models: a practical model, a psychological model, and a spiritual model. So the practical model is perhaps the model of self-care that we're all most familiar with, and probably how most of us practice self-care when we don't really think about self-care. And that is that we have good professional boundaries, and our professional persona, whether it's symbolized in a uniform or wearing a stethoscope around one's neck, one's professional persona is protective. It's communicative. It communicates to the patient, to the family, to others who you are, what you do, what you're bringing. But there's also a certain protection in that persona. So it's a sort of suit of armor in a way. And then the other part of the practical model is really not just having good professional boundaries, taking your lunch break, finishing on time, maybe having a routine when you get home where you kind of change into your home clothes. But then whatever it is, you then actually engage in the rest of your life. But specifically take time on certain occasions to really engage in activities that restore and renew you. And whether that's for a lot of people, that's physical activities, whether that's going for a walk, taking a run, do some yoga. There are many different types of physical and practical things that one can do. So that is, in essence, the practical model. And the practical model is very functional. And indeed, I'm talking about these three models not in any linear way. Each model has its time and its place and its own value. And so the implication is not that one is better than the other. It's really that there is a time and a place for each of these ways of practicing self-care. One of the downsides of the practical model, though, is that if we exclusively rely on this way of self-care, studies show that over time it leads to clinicians being less empathic. So it's like as though that suit of armor which we put on in kind of when we find ourselves in a stressful situation, it's not so much a shield as it kind of it sticks, and we can't easily go back and forth to being more empathic and then kind of more protected. If we exclusively rely on this approach to self-care, it's as though whenever we're in the work setting, and perhaps it even follows us outside the work setting, but that coat of armor is with us. Protective, yes, protective, but if you're on the other side of that coat of armor, you're feeling a certain distance, you're feeling a certain coldness, you're feeling a certain detachment. And what the studies show is that clinicians that rely on this form of self-care actually experience their work as less rewarding. So then what we spent a lot of our time talking about in our paper was the psychological model of self-care, or a self-awareness-based model of self-care. And there's really a sort of a triad that's kind of synergistic of three different elements of this psychological model. Mindfulness, which we'll be hearing more about from Ursula. Self-knowledge, which I've just been hearing about the Schwartz rounds, and that's clearly a big piece of that practice, and self-compassion. And so one of the phrases we used in our article was that self-awareness-based self-care is like learning to breathe underwater. That was the phrase we used. So, that was just dropped in there in the middle of the article. And one of the things I discovered writing for this particular, maybe it's all medical journals, but certainly for this medical journal, is that every statement had to be backed up by a research article or by, hard data. So I'd put this phrase in, and then the JAMA editor would take it out and send it back, and I'd put it back in again, and we're going back and forth like this. And so in the end, she wrote to me again and said, one last question. Can you please explain the importance of the breathing underwater metaphor? I keep deleting it because people can't breathe underwater. So to me, the metaphor would mean that self-care with self-awareness is impossible. Since you keep putting it back in, can you explain why this particular metaphor is important? So I said, look, with the traditional models of self-care, the practical model, what I'm calling here the practical model, it's like as though in some ways with our strong boundaries, our clear boundaries, we're holding our breath underwater in those stressful situations, so we're not overwhelmed, so we don't literally drown in it all. We kind of hold our breath, and then we come up for air, when we have a break, whether it's our tea break or whether it's when we go home in the evening. But what self-awareness does is it actually creates, it's like a sort of a bubble of oxygen that it creates that allows us to be in what are sometimes very stressful situations, but with this sort of expanded awareness that allows us to kind of find oxygen in the work itself that can sustain us. And so let's just look a little more closely at those three pieces. Self-knowledge, and we'll hear more about it from Jer and in their presentation shortly, includes the clinician's understanding of her, his family, religious and cultural background, of our emotional and psychological process. And having taken some time, however we do that, whether it's in something like a kind of a structured, reflective practice, like the Schwartz rounds, or whether it's through journaling, or whether it's in therapy or counseling, or whether it's in how we debrief with our friends, or how we just debrief on our own. Although I think there really is something to be said for doing this kind of work with another, whether that's in a formal or an informal way. Becoming aware of issues that could either prejudice or interfere with our clinical practice. Cultivating mindfulness, and we'll hear more about this from Ursula, but we're talking here, when we talk about mindfulness, we're talking about the purposeful, non-judgmental attentiveness to our own experience, thoughts, and feelings. A practice that can be cultivated through mindfulness meditation. And mindfulness enhances innate cognitive capacities. It's not as though mindfulness creates something new. We already have the capacity to be highly present. We already have the capacity to be highly focused. Mindfulness enhances that. And at the same time, it does something else. It allows the practitioner in the situation, in the moment, to monitor her or his subjective experience and interactions with others and the environment. What's sometimes referred to as meta-awareness or dual awareness. So you're in the situation, and you're actually able to be highly present and to notice what's happening in your interaction with the other person, and you're able to experience that interaction, and at the same time as you're experiencing that interaction, you're able to kind of monitor what's going on. And those of you that practice mindfulness will know what I'm talking about. It's hard to describe it. But that allows us to move in a little closer, to step back if we need to kind of, put our hands up internally and maybe say, I need to ask a colleague to come and help here if we need to actually step out of a situation that's too stressful. So instead of having a rigid coat of armor, what we have is more like it's still it gives us a protective boundary, but it's more like if you think of the pupil in the eye and how in low light conditions the pupil dilates, and in bright conditions the pupil of the eye constricts. That it's a bit like that. Our protective shield is much more responsive to the individual circumstances we're in. So mindfulness enhances that capacity. And self-compassion, because both self-knowledge and mindfulness can bring us into situations where we either see aspects of ourselves that we don't like, or if we really say, okay, I'm going to give this mindfulness thing a go, and we realize in a 10-minute sitting session trying to stay with the sensations of our breathing, our thoughts take us off 1,000 times, and we just can feel so frustrated and such a failure. So that's why we need self-compassion. Being aware that we have, most of us, very strong tendencies for self-judgment, for self-criticism, and taking time to work through these feelings, and cultivating an attitude of kindness towards ourselves. So that triad of mindfulness, self-knowledge, self-compassion can help to create that spacious kind of awareness that allows us to breathe underwater. That's unfortunately not where most of us are most of the time. And most of us, and speaking for myself, I realize I'm mostly, or certainly was mostly before I was perhaps taking some time to practice mindfulness, in what we might call reactive awareness, as a kind of default mode. And that describes how in times of distress and stress, instead of kind of moving to a more spacious place, our awareness tends to constrict and contract, and we get a kind of more narrow view of reality, where trigger events can really unleash a cascade of reactive feelings and a cascade of reactive behaviors. So mindfulness, self-knowledge, self-compassion are really an antidote to reactive awareness. Of course, we'll still have our moments, especially when we're tired and hungry and underpaid and underappreciated. Those will be the kind of circumstances that will make it more likely. Which is why it's so important that we take time to develop a sort of the background field of awareness, and the quality of the background field of awareness. So let me just say a little bit more what I mean by that. That we really can cultivate self-awareness so that we can practice it in the situations I've just been describing. And it's a two-step process. The first is, engaging in practices that actually cultivate these qualities. The second is actually taking that with us into the moment of engagement. So in terms of the paper, as I say, every statement we made, apart from that one of breathing underwater, had to have a kind of research link, had to have data supporting it. And the strongest data supporting the cultivation of self-awareness was there at the time for mindfulness meditation and reflective writing. Other practices that have supportive data are supervision, mentoring, peer group support, educational initiatives such as this, research initiatives, psychotherapy, spiritual direction. And then what I mean by applying self-awareness skills in the moment is Richard Harrison, who was one of my co-authors in the paper, clinical psychologist, had just done his doctoral thesis on working with a group of trauma therapists. So if you think of what I said earlier about vicarious traumatizations, trauma therapists would be the group who would be most vulnerable to vicarious traumatization that you could imagine. They're sitting there for an hour with somebody who's been traumatized in some serious way. But his focus in his study was on a group of peer-nominated trauma therapists who were identified as thriving in their work. And these are all established. These are all working in the field for at least 10 years. It's not just that they've just arrived. So what he did is he did this qualitative research where he interviewed this group of therapists, then he analyzed their responses to kind of find common elements, and he identified, I think it was 9 different practices. And one of these practices was practicing what he and his co-author called exquisite empathy. If you think what I said earlier about Charles Figley's work and how he says empathy is clearly a good thing for the clinician to have with their patient, but we need to realize it makes us vulnerable. They wanted to come up with a kind of a qualifier to empathy, and the qualifier was this word exquisite empathy. And they defined what they meant by that as the capacity to be highly present, to be sensitively attuned, to be finely boundaried in a way in contrast to rigidly boundaried, but kind of that dynamic boundary, and heartfelt, a kind of a warm, heartfelt presence. And the key is that they said that what makes exquisite empathy possible is self-awareness. And indeed, self-awareness was the common element to all of the 9 practices that they identify in their paper. So, back to the kind of personal dimension of this story, and then kind of a disclaimer at this point, it's going to get more personal as we go along. But as I say, I realized when I looked at the symptoms of burnout that I was experiencing some of these. And I probably wasn't way out on the far end of that spectrum of burnout. I was probably around there. And then I realized that there were things I could do, and I was doing them. Before I had a name for it, I was, in my own way, engaged in a kind of practical model of self-care. I was pretty good at, leaving work and engaging in activities outside work when I was there. And I was now really seriously engaged in cultivating a mindfulness practice, and I'd been in therapy in one shape or form for 100 years, and so I was sort of practicing these different models, and but I realized, it hadn't got me very far. It got me somewhere. I was moving. I was in a different place. I wasn't so exhausted the whole time. There was a little more kind of enthusiasm in, when I kind of went into work in the morning. But I still was doing a lot of fantasizing about being elsewhere, doing a different kind of work. So, maybe the issue was I needed to move into a different kind of work, but the combination of that with those other symptoms of burnout, maybe less intense but still there, made me realize I was still burnt out. Burnt out, maybe mindfully burnt out, but still burnt out. So around this time, I had summer holidays, and I came with my family to West Cork, where I've actually just been for a few days. And it's about 10 degrees warmer at least than it is here in Dublin. But anyway, I was there for 2 weeks and had a really lovely holiday, out mackerel fishing every day, and, just with my extended family and having a lovely time. And so really doing those sort of things that I knew renewed me and refreshed me. And after 2 weeks, I came back to where I work, Santa Barbara Cottage Hospital. And that's Santa Barbara Cottage Hospital on a cloudy day. Usually, well, California has been in a drought now for the last 6 years, but luckily this winter passing, we've had some rain, and it's kind of strange for an Irishman to be so happy to see rain, but you kind of, when you're there for a while, you realize why. So I arrived back to work, and it was a Monday morning, came in, and as we begin, I spent half of all my work is clinical. I do a little bit of teaching, but thankfully I don't have an administrative role as part of what I do, thankfully for me, because I'm not good at it, and others are, and I'm very happy for them to do it. So it means that I do the clinical, and I've been, which is partly why I've had to really ask these questions for myself. How do I find a way of sustaining myself in this work when I'm at the bedside, 8 hours a day, every day? So the day begins for me on a Monday, sitting in the palliative care office in the hospital with the team, and specifically hearing from the nurse who's been the on-call nurse for the hospital for the weekend. There's been a doctor on call too, but the nurse has been there, for the 8-hour shift or whatever it is. And so she knows better than anybody what's happened over the weekend. And so she's there, and she's giving us a report of the patients on our list. And I can't remember how many it was that morning, but it was somewhere between 10 and 20 patients. And she started at the first patient, and she kind of described what was happening. And then she went on to the next patient. She described what was happening. And then she went on to the next patient, described what was happening. And as she started talking and continued talking, I realized, this is what I hear at least twice every day, maybe 3 times, as I sit through different clinical meetings, triage meetings. But there was something different about that particular Monday, because I was coming back in a whole different place to where I am on a normal Monday. I was relaxed. I was somehow I'd let my defenses down. Somehow that kind of coat of armor, which didn't even realize was in place, had slipped a little bit. And I was sitting there, and I was listening to the story of a young man who he was now, he'd advanced pancreatic cancer. He was a widower. He had 3 young children, one of whom was autistic. He had every possible treatment he could have in terms of surgery, chemo. He was now engaged in an experimental chemo down at UCLA, which he was commuting down to. It was causing a lot of toxicity. He had a lot of pain, but he was just so desperate to continue in treatment because of his family. And I was just listening to this, and I kind of realized a couple of things as I was listening. This is the kind of story, as all of you know, that we hear every day. And but what I was realizing on this particular morning is that it was really hard to hear this, given how I was feeling on that particular morning. Just it was hurt. It was painful. That's the word I'm looking for. It was actually painful to hear this, and so what kind of came to me, as I say, it was painful to listen to these stories, and I began to think, if it's painful to listen to these stories on this particular Monday, well, it's painful to listen to these stories every time, but I'm finding some way of doing it that I don't register it quite as intensely as on this particular morning, when I was feeling like a kind of a soft-shell crab. That was the image that came to me. And what I realized is that the work we do exposes us to a lot of pain, a lot of suffering, a lot of grief, inevitably. And not just those of us that are doing this work, but I think it's probably a characteristic of being alive as a human being in the world. We're sensitive. We feel pain. But those of us that do this work are encountering human suffering and pain on a scale and intensity and day after day, week after week, month after month, year after year, that other people in other occupations aren't exposed to in the same kind of way. And that is taking a toll. So occupational stress in terms of that kind of, I'll say more about that in just a moment. But I realized at that moment that I just didn't have a good way of dealing with this. In fact, I realized I didn't have any way of dealing with this sort of chronic heart pain that was taking place. And then I thought, so the burnout is the common endpoint, and organizational stress and mismatch leads there. Values mismatch, as in moral distress syndrome, leads there. And then in the acute, short-lived, intense situations, interacting with another person's pain and suffering, causing secondary traumatization or vicarious traumatization, leads there or can lead there. But what those of us that are doing this work long-term are particularly vulnerable to is a sort of chronic version of vicarious traumatization, a sort of chronically interacting with somebody else's pain, suffering. Trauma can take its toll, and that toll can become chronic and can become cumulative. And so it led me to a question, and the question is there another less destructive way, one that doesn't take such a toll of being with my pain? Is there another way of being with our pain that is less destructive? So I'm going to let that question hang there for just a moment before I go into kind of the next part of my talk and the final part of my talk. But I just want to pause there for a moment and see if anybody at this point would like to ask any questions about the first part of the talk, specifically about the occupational stress syndromes, the practical and psychological models as I've talked about them.